So existing literature talks about that how telemedicine has led to improvement in information sharing, making successful referrals, improved clinical outcomes, and reduced transportation costs. So in this paper, how do we do things differently? We talk about, we investigate the causal impact of telehealth or telemedicine as an add-on to an existing health microinsurance program on outcomes such as health outcomes, health experience, and empowerment of the female borrower. We do find suggestive evidence that this service can lead to an improvement in self-reported physical and mental health, a better healthcare experience, and an improved perception of the female being more involved in the household decision-making. So the importance of this topic is nested in the deteriorating health statistics in Pakistan. There's a serious gap in access to healthcare between the rich and poor, where you'll see that poor income households spend around 6.6% of their household income on health expenditure, in contrast to a mere 1.3% by households in the upper income quintile. This goes to show that health expenditures constitute a substantial outflow of money for poor households. So this dearth of health services partly explains that why Pakistan fares so poorly on health statistics such as infant and maternal mortality ratio in contrast with South Asian counterparts. Not surprisingly, when we look at public spending, it constitutes a mere 1.1% of its GDP. To fill in this gap, the private sector has stepped in, though it comes at an exorbitant cost. So in this context, a renowned MFI decided to introduce or bundle health insurance with its existing microfinance program in 2014. The program initially covered hospitalization up to 30,000 rupees, which amounts to 127 pounds. After the success of this program, the MFI decided to complement this service with OPD services, where patients could access doctors remotely. This service would be provided at the branch site. This is an innovative approach by the private sector to make healthcare more affordable for the disadvantaged group in the society, specifically women. Note that this program would be available to the borrowers at less than £1 per hospital visit. So a bit about the program. The program was piloted in one of the 25 branches in Lahore, which is an urban metropolitan city in Pakistan. The main purpose for introducing the service was to ease binding constraints such as distance to the healthcare facility and availability of a doctor. We then select the control branch using a balance test where we match branches based on branch level characteristics such as branch age, client base, and utilization of the initial health insurance program. So just to give it away, all individuals belonging to the branch where the telehealth service was provided are termed as treated individuals, and all borrowers belonging to the other branch are termed as the control group. Data, we started collecting our baseline data from May to June 2019, right before the program was piloted in July 2019. We started collecting our inline data in from January to July 2020. So this gives us an exposure period of 6 months. Note that there was the outbreak of COVID during our inline survey, which did affect our survey negatively, and I'm going to talk about it later. So in the survey, we collect information on self-reported physical and mental health, perception about the program, perception about the female status within the household, and of course, socioeconomic status. So this survey was conducted over the phone and by female enumerators. This exercise enabled us to collect information on 2,067 clients at baseline and 1,218 unique clients at inline. Our results are strictly for the balanced panel, which is 1,218 individuals. Our main variables of interest are self-reported physical health. How do we calculate this? So we asked females to report how they felt on most days, which was to be reported on a Likert scale from 1 to 5, 1 denoting wellness and 5 denoting extremely sick. We then used this to construct a dummy variable equal to 1 if the female replied by saying that they felt sick or extremely sick, 0 otherwise. For mental health, we use the standard general anxiety disorder index, which is calibrated on a scale from 0 to 21. And we asked respondent questions such as, did they feel irritable? How anxious were they? And whether they experienced any symptoms of anxiety. So the scale is calibrated in such a way that higher levels denote higher levels of anxiety and lower levels are associated with no or mild anxiety. For empowerment, we use 2 main questions. The first one is that whether the female is allowed to travel outside the house alone. And the second one is that how frequently is she consulted in household decision-making matters. And lastly, by convention, we collect information on socioeconomic status, such as age, education, and asset ownership, which we include as controls in our regression. So what does our sample look like at baseline? Note that these are 1,218 individuals that we're talking about. So 1/4 respondent report feeling sick. Majority did not feel any symptoms of anxiety and were relatively empowered. We do achieve a balance between the treatment and control group, except for variables in age and house ownership, but we control for that in our regressions. Moving on, our empirical strategy uses an OLS estimation technique where we talk about the average impact of the treatment or the provision of telehealth medicine on our female borrowers from baseline to end line. YIJT is our outcomes of interest, where I denotes female borrower I, J denotes the branch, and T represents the time variable. TJ is the treatment variable, equivalent to 1 for the branch where the treatment was provided and 0 for the control branch. Beta is the parameter of interest. YI node are the baseline level of outcomes. Z is the vector of controls, which are the socioeconomic controls. Mu represents the age fixed effects, and epsilon is by default the idiosyncratic error term. So we use an INCOVA technique with age cohorts, and standard errors are clustered at the individual level. We report the intent to treat estimates, which is the average impact of the program for the treated group as compared to the control group. And we prefer this to the late effects because we're talking about measures such as self-reported physical and mental health and empowerment measures. And from a policy standpoint, it makes more sense to report the ITT estimates as compared to the late effects. As robustness checks, we use propensity score matching to match treated and control borrowers. And then based on the match sample, we run a definitive estimation. Moving on to results. So first, we present we see at first stage what exactly is happening, how many of the women in the treated group are actually using the service. So we find that treated borrowers are almost 4 percentage points more likely to use the program as compared to the control group. And of those who did use the service, 2/3 report an improvement in perception about their ability to perform day-to-day tasks, their ability to avail healthcare, and an improvement in health outcomes. So this is how we're terming welfare over here. Moving on to our main results. So what impact did this program have on physical health? So treated women are 14 percentage points less likely to fall sick and 8 percentage points less likely to experience symptoms of illness.
Sorry.
You see a similar...
You have 5 more minutes.
Oh, okay. So we observe a similar pattern for mental health as well, where treated women are 2% report 2 levels lower GAD in score 2 points lower in the GAD index as compared to the control group. To see what exactly is driving these results, we look at the health experience of these women, and we find that treated women are 4 to 7 percentage points more likely to seek treatment for themselves and their family relative to the control group. And it's assuring to see that the coefficient is highest for the female. So is it because that treated women are falling sick and therefore have higher health needs? We rule out this possibility because control group at end line or control females are twice as likely to fall sick at end line. So we rule the possibility out that treated women are more likely to fall sick. Moreover, we observe that treated women are also seeking healthcare more actively and quickly, as denoted by the days coefficient over here. To see the impact on pecuniary and non-pecuniary health treatment cost, we find no significant effect on health cost. However, we do observe that treated women incur a higher transport cost and a longer waiting time. We attribute the higher transport cost by looking at descriptives, and we see that this is primarily or could be because that treated women are using private transport to use these health services as compared to the control group. Lastly, looking at the impact on empowerment, we find that treated women are 7 percentage points more likely to be consulted in household decision-making. And this resonates with the literature on microfinance, where we find that after receiving the loan, the female did report an improvement in empowerment. So to sum up, in this study, we talk about the impact of a 6-month exposure to a telehealth service as an add-on to an existing health microinsurance program. We find evidence that, that this program could perhaps lead to an improvement in self-reported physical and mental health and an improvement in perception about female empowerment. Potential mechanisms that could be at play here is that these women, the treated women, are seeking healthcare more actively and quickly, and also they are being consulted in household decision matters as compared to the control females. One caveat to our finding is, unfortunately, a very high attrition rate of 40% and a differential attrition of 17%. We attribute this significant attrition due to COVID, because note that we decided to conduct the survey for the treatment group before the outbreak of COVID for the treated group and later for the control group. So that explains that why we had a lower response rate for the control group. However, we do not observe that attrition affects the covariates any differently because all these interaction terms come out to be insignificant. So hopefully that should kind of justify that attrition isn't that big of a threat to the findings of this study. Thank you.
Wonderful, and just in time. Thank you, Sadia. All right, so now we will carry on with the program. Next up is Daniel, who is joining us from Italy, if I'm not mistaken, right? Yeah, perfect. He's a PhD candidate from
Italy.
Cornell.
Let me get my slides up.
And I want to encourage all our listeners to keep on sending us your questions. It's better if you send them like during the presentations than waiting at the very end. You might, I don't know, forget, or just keep on sending them. So yeah, Daniel, over to you. As with Sadia, I will interrupt you when you've got 5 minutes left. So I'm sorry about that in advance.
You're okay.
Okay.
All right, thank you so much, Abelardo, and thank you so much, Sadia, for your presentation. I thought your paper was super interesting. My name is Dan. I am a PhD student at Cornell University, and I'm going to be presenting evidence to you from a randomized control trial in urban Malawi that granted women access to family planning services, and we look at how that affects human capital growth, particularly children's heights and their cognitive development. This is joint work with Professors Mahesh Kara and David Canning at Boston University and Harvard University, respectively. So let's jump into it. So I'm not going to insult your intelligence by reading my agenda to you, but I'm going to give you the bottom line up front. We'll talk exactly about, like, I'll give you a highline preview of the results before we jump into the theoretical framework and how we actually find these results. So what are we actually looking at here? And that is a randomized control trial that was conducted in Lilongwe, Malawi, that provided postpartum and pregnant women with access to a comprehensive family planning package that included counseling, transport, and a voucher for family planning services. So this is one of a series of papers that deals with this RCT. And this one specifically looks at how this family planning program affected the growth and development of children in participant households. So as this program focuses on pregnant and postpartum women, we have what we call an index child. That was the child who was no more than 6 months old at the time of baseline, or who was still in the womb. When we look at these children, they are about 1/4 of a standard deviation taller for their age at first-year follow-up, and perform 1/10 of a standard deviation better on this caregiver-reported cognitive development at second-year follow-up. So that's the interesting ITT result we find. And looking at like the causal mechanisms underlying, we use a causal mediation analysis to show that the changes that we observe in child health are not driven by changes in birth spacing, although we do observe those changes, but are rather driven by changes in health seeking, meaning that mothers and children are more likely to have visited a clinic in the last year if they were part of our intervention group. Now, this relates to the literature on the economics of fertility and Becker's original household model of fertility and a quality-quantity trade-off, as well as some more recent advances by Calvacanti I believe he's at Cambridge, dealing with how uncertainty in fertility enters the parental utility function for fertility. Now, let's jump into the theoretical framework and why we might expect family planning services to improve child health, right? So as I mentioned, the program includes contraceptive counseling, transport, and a voucher for services. Now, we think that that should increase contraceptive knowledge while also decreasing the implicit contraceptive price. And together, that those things should increase contraceptive use. Now, if these increases in contraceptive use should decrease households' perceived probability of getting pregnant at any given time, and that should increase the family's ability to invest limited household resources towards human capital investments and increase consumption through increased female labor participation, and that should increase human capital. Now, as I mentioned, this is also this biological pathway that is maternal depletion. That is, if birth spacing improves because of access to family planning services, that should have a biological effect on human capital. Now, that is true, and we show that even though that isn't the pathway driving these results, that is a totally plausible pathway. It is just in our case, we're looking at index children who were either born already or conceived by the time of our baseline survey. So their preceding birth interval is exogenous to our treatment assignment, meaning that they had already been conceived by the time we did our baseline. So we are not able to change the preceding birth interval. Now, one thing we need to show in this paper, and we do, is that women are actually using contraceptives to prevent pregnancy. There are many reasons women may use contraceptives, including control of their menstrual cycles and like reduction of HIV. And we show that 55% of women in our study group report using contraceptives to prevent pregnancy, and that among women who are using contraceptives, there is a significant decrease in the risk, the perceived risk of pregnancy at any given moment, and that women don't actually use contraceptives to decrease their birth parity in the long run, but rather to improve birth spacing in the short run. So now let's talk about the study sample a little bit. We look at 2,143 pregnant or postpartum women. Of those pregnant and postpartum women, 1,030 have given birth by the time of our baseline survey. Of those children that have ever been born, we're able to get height, weight, and anemia testing for 270 of those children, right? And that baseline survey took place in September of 2016, and our intervention started in November of 2016 with a rolling intervention start going along with the baseline survey. And that intervention went on until November of 2018, which coincided with our end-line survey. The program is individually randomized, and we show in the paper that characteristics are balanced across treatment and control. So let's go into the actual intervention a little bit more. I said that there was counseling. These are 6 family planning counselings that focus on the health benefits of birth spacing and the pros and cons of different contraceptive methods. And the counseling is delivered by trained Ministry of Health nurses over a 2-year intervention period at the home. This is complemented by a free transport that women are provided to the Good Health Clinic in Kalma, which is a high quality maternal and child health clinic in our study area. And that transport is conducted by a taxi that is hired exclusively for the study, meaning that women always have access to it. And that taxi is always accompanied by a female field manager. This way we overcome any kind of accessibility issues with women traveling alone to seek care. Now, finally, this is all complemented by the family planning reimbursement package we offer, which is roughly $25 US, 17,500 Malawian kwacha. Now, this covers any kind of family planning service that women want at the Good Health Kuma Clinic, except for abortion or sterilization. That isn't for any kind of moral reason or financial reason. It's just those services simply aren't offered at the Good Health Clinic in Kalma. So, bottom line up front, we have an issue with attrition in this study. So at first year follow-up, when we're conducting our height and weight measurement, we are able to resurvey 82.9% of women and 76.3% of the children, meaning that they're in the household when we're doing our survey. Now that attrition seems to be balanced across groups, meaning those who stay in the study across treatment and control are jointly similar. However, we do find differences between those who were not found and those who were not found in both the study and control, meaning that women who were less likely to be resurveyed were younger and less educated, meaning, and then we suspect that is likely because this is an urban setting where migration is high, and these women particularly were more likely to migrate out of the long way during our study period. However, we don't find that attrition is differential between treatment and control. The larger issue that we face in this study is with non-measurement. So out of the 1537 children that we find and we are able to survey, we're only able to get heights and weights for 720 of those children. Now, a lot of that has to do with the fact that there are a lot of traditional beliefs in the long way centered around the collection of blood. And in our case, our consent form for height and weight measurement was tied to our anemia surveying, which meant that there was a high rate of refusal for measurement in our study. However, much like the attrition that we face, this seems to be balanced across treatment and control groups. So while it's something we acknowledge and it is a risk to the study, we do not think it's a threat to our internal validity. So moving on to our actual estimation strategy. We conduct an ITT estimation where we conduct a reduced and a adjusted form, where in our reduced form, we still include month of birth 6 effects and a spline over children's age. Now this controls for any statistical artifacts that come with the measurements of heights and weights, meaning that children born in July and February in Malawi are likely to be shorter because at the time of their birth, food availability in the long way is traditionally lower. So that controls these fixed effects, and the spline for age control for these effects. Now, in our adjusted regression, we also include maternal characteristics such as education and age, and child characteristics such as birth order and biological sex. Finally, we control for an area fixed effect that controls the different areas and neighborhoods within the long way, and we do not cluster our standard errors because this is individually randomized. So, as I mentioned, we find that children are taller for their age and perform better on cognitive tests, and we want to dig a little bit into that black box. So we estimate the average causal mediation effect. Now, to abstract a little bit and look at this figure, what the average causal mediation effect is the pathway highlighted in red across this DAG, meaning it is the pathway that treatment affects our outcome through a mediator. Whereas the blue outcome is saying that for children's height, there is some direct effect between family planning services and child height and children's heights. Now that might be true.
Sorry.
5 minutes?
If you can wrap up in 5 minutes, yeah.
Thank you. That might be true, but in this case, we think that most of the effect is happening through changes in health seeking and changes in investment in human capital. Now, speeding up a little bit so I don't run out of time, we do this using a structural equation model displayed here, where we predict the mediator using a logit model. We use 2 different mediators. We use changes in birth spacing, and we use changes in health seeking. Now, we we conduct a procedure that is similar to bootstrapping, where we simulate these coefficients and then simulate them from their sampling distribution before actually mechanically calculating the potential outcomes from these simulated equations and mechanically calculating the causal mediation effect. So digging into our results a little bit, we show that our treatment impacted children's heights at first-year follow-up quite substantially for a program that doesn't actually target children's height. We find about 1/4 of a standard deviation increase in height for age, and we show that that is complemented by a 1/10 of a standard deviation increase in CREDI scores. Now, the CREDI is a caregiver-reported measure of cognitive development. It's a set of 20 questions about ages and stages that children have gone through in the first 2 years of their lives. So looking at this a little bit more, we show in the paper that the change in children's height is complemented by roughly a 7% decrease in the rate of stunting. Now that seems very large for a family planning program, and this figure kind of shows why. You can see here that at first-year follow-up, the modal child in your control group is right at that -2 standard deviation stunting threshold, meaning that any increase in child heights that we see largely reduces stunting. Now, whether or not we think that a child who is directly above the threshold is much healthier than a child who's directly below the threshold is up for debate. But either way, this shows that family planning services might be a viable pathway to fight childhood malnutrition. Now, digging into our causal mediation results a little bit, we show that the average causal mediation effect, meaning how much of our ITT effect is driven through each one of these mediators for healthcare usage, falls at about 0.05 standard deviation, meaning roughly 20 to 30% of our effect on children's height are explained by changes in health seeking. Now that's complemented by an average causal mediation effect of 0.03 for CREDI scores, which if you remember, there was a 1/10 of a standard deviation effect on CREDI scores on the ITT estimation, meaning that the changes in health seeking explain between 28 and 32% of the impacts that we see on CREDI scores. Now, we note that the mediator we're using here is a 0-1 variable for whether or not mothers and children actually visited a clinic within the last year. And we show that at first and second year follow-up, if you look at this row right here, we see a roughly 10% increase in the usage of healthcare among women in our treatment group. So we think that these results are promising and they support the quality-quantity trade-off. And had we had better data, more granular on healthcare usage, something along the lines of vaccinations and antenatal care, we'd be able to explain a much larger percentage of the effect that we find on children's height and disease scores. So to wrap up, so I don't run out of time, we conduct this RCT in Malawi that provides pregnant and postpartum women with this comprehensive family planning package. And we show that children are taller for their age at first-year follow-up and perform better on this caregiver reported of cognitive development at second-year follow-up. Now, altogether, these results imply that there are positive externalities associated with expanding family planning services that extend beyond the recipient woman. There's a strong case to be made for expanding family planning services as they are, and this just adds to the cost-benefit analysis that governments must go through when they're deciding how to allocate scarce resources, and builds the case for allocating those towards women and towards family planning services. Okay, that is all I have. Thank you very much.
Perfect, wonderful. Again, just in time, bang on time. Okay, we're gonna continue with the program. Now it's Eleonora's turn. Eleonora is joining us from the Netherlands. And just as before, I'm sorry about that. Just as before, Eleonora, I'm gonna interrupt you when you have 5 minutes left. So sorry about that in advance.
Thanks.
And to all our listeners, please do keep on sending us your questions. We're gonna have the Q&A session at the end, and we can call out the person who asks the question for them to unmute and ask the question directly to the speaker. And if for any reason you cannot unmute, we can read out the questions for you the purpose is to have an interaction with our speakers. So yeah, over to you, Eleonora.
Thank you very much for having me here today. So I'm going to present the results of a randomized trial that we did in Bangladesh on a menstrual health program. So this is joint work with my colleagues at Maastricht University, Lidwien Sol and Paul Smeets. Let me see how I can. So the motivation for this study is really, so every month 2 billion women have to manage their period, and they often have to do this in a secretive manner. There is this concept of period poverty that's prevalent in both high and low income countries, where women don't have access to sanitary pads, for example, because they can't afford them. But in addition to that, what we often observe in low and middle income countries is that there are very restrictive norms vis-a-vis menstruation for women. So women are being told that they cannot engage in certain activities. Sometimes they're even being ostracized from the village or from the community that they're in at the time that they're menstruating. We also know that around the time of the menarche, so that's the onset of menstruation, so the first menstruation, we see that gender-based gaps in education in low and middle income countries really widen. And that's really problematic, as we know from the literature that improving girls' education is one of the most cost-effective ways to spur development by increasing human capital accumulation, by having a higher age at marriage, etc. Now, there is some qualitative evidence that menses, so menstruation, is a key driver for girls' absence at school. Also, poor menstrual health practices are associated with lower academic achievement and adverse psychosocial outcomes. So there's some evidence of that. But there's very limited causal evidence. There is some quantitative evidence on menstrual health interventions. So there is evidence on that the provision of, say, menstrual products like sanitary pads has an impact on health and schooling outcomes, or that training interventions actually improve girls' school attendance. But few of these studies use rigorous evaluation designs, and many of them actually arrive at mixed results. So our contribution is that we have a rigorous cluster randomized design for a menstrual health intervention. And next to the standard survey methods that we're also using, we also have school administrative records. Plus we have what we call random spot checks to measure one of our key outcome variables, which is school absenteeism. So random spot checks are checks that are being done by a member of the research team, where they go to schools unannounced and basically check whether a particular girl is in school on that particular day, yes or no. So that is a much more objective measure, of course, than having self-reported surveys, or relying on school administrative records, where schools also have an incentive to misreport. Now, we also move beyond the typical health and schooling outcomes by also looking at psychosocial outcomes. So we think that such an intervention may also have an effect on empowerment and attitudes towards gender equality. Plus, given that, and I will talk in a minute about the actual intervention, given that the intervention has a holistic nature, so it's very multifaceted and targets not only girls, but also boys, we also look at the intervention effects on boys. So the setting, 40% of girls in Bangladesh report missing at least 3 days at school each month during their menstrual period. So that really indicates that this is a big issue. Our study is set in the rural district of Netrakona, which you can see colored red on a map. 74% lives below the poverty line. And this is a multifaceted NGO-led program. So the NGO is a Dutch NGO, CMAVI, and it has 2 treatment arms. And I'll talk in a minute about what these treatment arms comprise. We did a study in mixed junior secondary schools in 6 to 8 grades, where the kids are aged between 11 and 15. Now, this program is called RITU. And as I said, there are 2 treatment arms. Treatment arm 1 was school-based. So what they did there, they had a launching campaign to familiarize students and the staff with RITU. So they had discussion sessions, essay writing, and a screening of a reality TV show on TV. They also installed or improved menstrual health friendly toilets in accordance with WASH criteria, so water and sanitation and health criteria. And then they had these educational modules. So they were both focusing on menstrual health, but also puberty in general. And they were embedded in the school curriculum. They were taught bi-weekly to girls and to boys. They focused on improving menstrual health, knowledge and practices, and changing attitudes among both girls and boys towards menstruation. Now, the second treatment arm was a combination of treatment arm 1, so the school-based intervention, and a household intervention. So in treatment arm 2, we had, in addition to the school-based intervention, we had households of girls that would go to these particular schools. We had them invited for a 2-day group education session for fathers and mothers in the village that focused on improving knowledge, menstrual health practices, and promoting less restrictive norms towards menstruation. The parents would also receive information about available subsidy to build menstrual health proof toilet facilities at their home. And the parents were given a menstrual health booklet with visual reminders of the contents that were taught during the education sessions. We pilot tested that particular treatment arm with 30 out of sample parents prior to the intervention. So the evaluation design then, so as I said, we did a cluster randomized trial. We had 149 schools selected in 7 upazilas. So the upazilas are the regions in Bangladesh. We sampled 28 girls per school for our survey. So for our measurements, so all of the girls in grade 6 were essentially treated, but we sampled 28 girls per school. As I said, we had 2 treatment arms plus a control group. We stratified on upazila, school attendance, existing toilet facilities at the school, and we did that on the basis of pilot data that we collected earlier. We had 3 data collection rounds. So we did a baseline in 2017, a midline in 2019, and an end line in 2021. What I'm presenting today is the results of the midterm evaluation. So really only using the baseline and the midterm data. And we registered a pre-analysis plan with the EAE RCT registry. Okay, so the key hypothesis that we are testing in the study is that, first of all, we think that RITU lowers school absenteeism among post-menarche girls, so among girls that already are menstruating. Second key hypothesis is that we think that RITU has a positive effect on psychosocial well-being, gender attitudes, and aspirations. The third one is that RITU has a positive effect on menstrual health practices. And our fourth key hypothesis is that RITU would lower school absenteeism, not only for girls, but also among boys. Okay, so our empirical strategy is pretty straightforward. We measure ITT effects. So we have our outcome variable I with subscript I, Y with subscript I for the girl and J for school. Then we include our 2 treatment arms we have a set of control variables denoted by the vector x and the error term. So our baseline control variables here are listed. So socioeconomic status, number of female household members, the distance to school, the age at menarche, so the onset of the menstruation, school size, and the number of menstrual health friendly toilets at the school. So as I said earlier, we have 3 outcome measures for school absenteeism. And I'm gonna quickly talk you through how we measure that. So we have administrative records. So there, the absent rate for each girl is calculated as the number of days absent divided by the number of open school days. For the self-reported survey, it's the self-reported number of absent days for a girl, also divided by the number of open school days. And for our spot check data, we have the absence rate for a particular girl, which is the number of times that person is absent during the spot check rounds, divided by the total number of spot check rounds.
Sorry, Eleonora, if you can wrap up in the next 5 minutes. Great,
sure.
Thank you.
So our key outcomes, in addition to school absenteeism, are these psychosocial well-being and empowerment outcomes. I will not, just to make sure that we're ending in time, I will not go through all of them, but basically we have indices of mental health, subjective well-being, and empowerment. Then when it comes to the key outcomes for dropout rates and the effects on boys, we have that as well. Plus we have these menstrual health practices that we also believe might change as a result of the intervention. So I first will show you some descriptives. So these are the descriptors for our 3 measures of school absenteeism. So what we see here is that self-reported survey data, so that's the green bar, actually shows that absence is not so much of an issue. So self-reported survey data only gets us to absence of about 15%. If we then compare that to the school records, that's already closer to 40%. But if we rely on the spot check data, we actually see that absence is a really big problem, because absence rate using the spot check data is actually more than 50%. Okay, so let's have a look at our regression results. What we see here, so for the 3 measures of school absenteeism, we see in the first row, we see that our treatment arm 1, so the school program only, has a significant effect on school absenteeism. So if we look at the first 2 columns, these are the columns for the school records. Column 3 and 4 are for the survey data, and 5 and 6 are for the spot check data. Now, what we observe are that these effects are pretty large. So these are effects in percentage points. So if we focus on the columns that actually include the controls, we actually see that the school program has an effect of 10 percentage points decrease of school absenteeism. If we look at the survey questions, that effect is getting smaller, and the effect is even getting much smaller and less significant when it comes to the spot check data. We also see that if we look at treatment arm 2, that there's still an effect, but if we then compare whether there is a differential effect, so an increased additional effect of that household component, we actually see that there's no difference. So in the table, you can actually see that in the row that says p-value T1 equals T2, where we actually test for the equality of coefficients. And we don't see that there is a difference, which is very important in terms of the cost effectiveness of this program, because going to the households in addition to the schools actually increases the cost manifold of this of such an intervention. Very quickly then on the other outcomes, what we see is that when it comes to psychosocial well-being, we do not really find much when it comes to a general increase in mental health or subjective well-being, but we do find something when it comes to asking specifically for these issues related to menstrual during their menstrual period. So we ask whether they're more or less likely to be embarrassed during menstruation, whether they're more insecure, and we do find some effects there. Treatment effect on the likelihood of dropout. Also there, we actually find that there's quite a substantial effect. We see that dropout rates in the control group are about 50%. And we also see that the school program has an effect of a decrease of 5 percentage points on dropouts. Empowerment outcomes, we do not really find much there when it comes to the school intervention, but we do see that there is an impact from the household intervention. Menstrual practices, again, we find generally positive results, except for the last column, which I call it red. So we do find that the frequency of wearing dry sanitary pads actually decreases for the treatment group. And we think that might have to do with the fact that girls are more aware that they're actually wearing non-dry sanitary pads, or because they also are more likely to change their sanitary pads at a more frequent rate, there's less time for washing and drying. So that might also be a reason.
Sorry, Eleonora, if you can wrap up in the next couple of minutes.
Yes. One of the final results, the effect on boys. So we also find that there is a substantial effect of the intervention on boys' absenteeism. So here we see that the control mean is actually pretty high for boys. So absence rates are about 50%, but the school program actually reduces that by 10 percentage points. And then finally, we also checked whether this might be due to a program that basically gets girls to come more to school for other reasons than a targeted menstrual health intervention. But if we look at the subgroup of girls that have not yet started to menstruate, we actually find no effect. So our conclusion, this is the first evidence of impacts of mental health training interventions that reduce school absenteeism. We find that the combined intervention does not have any additional impacts in most cases. We also find that the effects are really smaller for our most objective measure. And the boys' absence rates are also lowered, but there's no effect on pre-managed girls, suggesting the program might, on the one hand, have been very inclusive and rightly targeted. Thank you.
Wonderful, thank you, Eleonora. Okay, so now we will move on to Kibrom, who is joining us from DC, so it must be really early in the morning over there. And you are muted, Kibrom.
So can you guys see it?
Yep, and we can hear you clearly.
Perfect. Yeah, it indeed is early morning, and I'm more of an afternoon person, so it's a bit of a struggle joining.
I'll give you a 5-minute warning. Okay.
Okay. Yeah.
Perfect.
So the paper I'm presenting today looks at the effects of access to mobile phones on infant mortality in Africa. This is joint work with Justice Mensa at the IFC and Kibrom at IFPRI. So this work is a bit different from the previous presentations, impressive presentations. This is more of research using administrative data rather than randomized controlled trials. Okay, let's jump in. So to motivate this work, I'll start by noting that over the last 2 decades or so, digital technologies such as mobile phones, the internet have revolutionized the way we communicate and how services are delivered. And this has become even more apparent during the COVID-19 pandemic, when the nature of work and the way we pretty much communicate changed dramatically. Digital technologies are especially important in developing countries where access to hard infrastructure, such as roads and health facilities, is limited. In that sense, in the context we study, which is Africa, we have witnessed dramatic increase in the number of households who have access to mobile phone coverage. This figure going up from approximately 80 million in 1999 to roughly 850 million in 2020. Our outcome variable is infant mortality, and it's fairly straightforward to motivate why infant mortality matters. So we know infant mortality is an important metric of societal health, and its reduction is an important measure of social advancement. In that regard, the last few decades, especially the last 3 decades, have recorded dramatic drop in the number of days per 1,000 live births globally. That figure going down from 65 in 1990 to roughly 28 in 2019. But significant regional differences remain, and Sub-Saharan Africa is still home to the highest infant mortality rates, with 52 days per 1,000 live births. And the main cause of this relatively high infant mortality rate in Africa are considered to be complications during births, premature births, and early childhood disease such as malaria and diarrhea. So in this paper, we try and answer the question, does access to mobile phone reduce infant mortality in Africa? So mobile phone technologies are not designed to reduce infant mortality. So effectively what we study here is the spillover impact of a technology that was meant to do something else. And I'll try and give you kind of a feel of what the potential mechanisms are as well in this paper. So we hypothesize there are at least 3 ways in which mobile phones can affect infant mortality rate. The first one is access to health information. Mobile phone technology facilitates communication between healthcare providers and end users, as well as among communities. And it improves the delivery of health information through mediums such as SMS, messaging, voice calls, or video calls. The second channel is health service delivery, and actually a couple of the papers we presented before me are focused on this. So mobile phone technologies open avenues for creative application of new technology to reach populations that are underserved in terms of access to health services, and this can be through telemedicine or telehealth apps that are now fairly popular in the African context. And the other contexts in which this could be, mobile phone technologies could be useful or could reduce infant mortality is during health emergencies. And there is this paper by Gonzalez and Mafioli, who studies the effects of mobile technologies during the Ebola crisis in Liberia, and it shows that one of the important mechanisms through which it was able to achieve reduced Ebola rates is because now households who have Ebola can quickly reach out to health professionals. So during emergency, this could have significant implication to health services. The third channel is a more general impact through economic activity, kind of mobile phones can increase employment, consumption, incomes, and reduce poverty, and this would show in reduced infant mortality rates. So in this paper, we use 3 types of data. The first data is health data, and this comes primarily from the demographic health surveys, and we use DHS data from 25 African countries that have, for which we have mobile coverage data. And our sample includes children born between 1998 and 2006. This is 2016, and this is informed by our mobile coverage data, the coverage period for the coverage data, for the mobile data. And our mobile coverage data comes from Collins Bartholomew, a digital mapping company, and they compiled the mobile coverage in Africa from 2 sources, from mobile network operators and the GSMA, and open source data from cell towers. And we combine this with population density maps to calculate mobile coverage rate in 11 by 11 kilometer grid cells. The third group of data sets we use in this paper are climate infrastructure data, and it will become apparent how we use this. So we use lightning intensity data from NASA, temperature and precipitation data, nightlight luminosity, and a spatial database of health facilities in Africa by Mina and et al., a more recent data set that covers 50 countries in Africa and approximately 100,000 health facilities, public from the public sector. And we combine these four data sets with ICOM's PMA data to kind of measure performance of facilities. So it will be clear as I discuss the results how this will be used. So to give a sense of our identification strategy, pretty much, which comes from variation in mobile coverage rate over time. So here, this polygons are admin 1 levels in Africa. We have this data at smaller administrative divisions, but it's just difficult to see in a map. So this is present at the admin 1 level. You can see in the top one, which is trends in second generation mobile coverage. Second generation covers just voice and SMS messaging, and the bottom panel covers 3G technologies. 3G technologies include, on top of voice and SMS, internet services. You see that there has been dramatic increase in 2G coverage between 1999 and 2018, but progress in 3G technologies is not as fast. So you see, it's just that 3G technologies are primarily concentrated in Egypt, in Southern Africa, and some in Western Africa, around Ghana, Nigeria. Yeah, to give you a feel of what we try and do here, so we aggregate the data at the DHS sample level. Here, for example, ML01 is the 2001 sample in Mali. CR11 is the Côte d'Ivoire sample for 2011. And so here we plot the average infant mortality rate for each DHS survey against mobile coverage rate. And you see there is a negative relationship between the two, and there is strong correlation of minus 0.56. Here, to be clear, our mobile coverage rate is defined as percentage of people in each grid cell, the grid cell being an 11 kilometer by 11 kilometer space area. So it's the percentage of people in each grid cell living in an area with network coverage. And this measure goes from 0 to 1. 0 means no coverage, and 100% coverage in the grid cell area. So our baseline specification is 2A fixed effects, where we regress infant mortality on mobile coverage rate. And in this setup, we have control for grid fixed effects here, birth year fixed effect, birth month fixed effect, and a range of controls. Here we have child characteristics such as birth order, child gender, mother characteristics, and grid characteristics. And this includes temperature, precipitation, night lights, etc. A bunch of variables. But so defined, our key parameter alpha-1 does not identify causal impact of mobile coverage on infant mortality, because mobile coverage does not necessarily evolve exogenously over time. There is a good reason to believe this is an endogenous variable. At least we can think of 2 reasons why this might be endogenous. One, because mobile operators prioritize areas with high economic potential in their expansion plans. And these areas tend to be urban, have access to other infrastructure, have higher incomes, and perhaps lower infant mortality rates. So,
sorry, you have 5 more minutes.
Oh, really? Already? Okay, good. Okay. And the second factor is potentially coincidence of expansion of health, so mobile technology with other public infrastructure may confound our results. So our preferred specification is IV, and in our IV, we instrument for mobile coverage with lightning intensity. We believe lightning intensity is a relevant instrument for mobile coverage because electrostatic waves from lightning cause voltage surge, and this leads to destruction of the electronic components of digital infrastructure. So to kind of mitigate against this, mobile operators install surge protectors, and these are expensive, which means areas with high lightning activity, for which it is the mobile expansion is likely to be expensive, see lower expansion of mobile technology. So this instrument has been used in Manacorda thesis, Econometrica paper, and Gurrievita's QJE paper. So basically our exclusion restriction here is conditional or on our controls. Lightning activity affects infant mortality only through mobile phones. So this is our empirical strategy. Basically, first stage, we regress mobile coverage on our instrument, and second stage, we regress infant mortality on our predicted mobile coverage. So moving on to results. So the OLS results you see here show that mobile coverage is negatively related to infant mortality. And as I showed earlier, this may not necessarily be causal. Then we move on to our IV estimates. So here, so we have like two sets of results. The first two sets of results use grid fixed effect, and the second one country fixed effect. So our preferred specification one that uses grid fixed effect. And if I could focus your attention to column 2, where we control for everything, you see roughly like a 10% increase in mobile coverage rate is associated with 0.45 percentage points decrease in infant mortality. To put this in perspective, in context, this is roughly 3 infant deaths per 1,000 live births saved for a 10% percentage point increase in mobile technology. So to kind of look at the channels through this happens, so I'll try and start with infant mortality, health knowledge, preventive behavior, health care utilization, and then child health, kind of the full circle. Quickly, I'll walk you through that. And here you see there is significant improvement in health knowledge. Mothers who report they know ORS to be kind of a treatment for child diarrhea is higher in areas with mobile coverage. So information on TB, beliefs on tuberculosis are better in areas with better mobile coverage. In terms of health behavior, so as I mentioned earlier, malaria is an important determinant of infant mortality in Africa. And when it comes to that, so we see in areas with better mobile coverage, the use of bed nets, both for mothers and children, is better. Reduced open defecation and better hygienic practices, kind of disposal, so hygienic disposal kids' stools. So in terms of healthcare utilization, we have some variables on vaccination rates and prenatal care utilization by mothers. You see across the board, greater rates of vaccination, vitamin A supplementation, and improved prenatal care at health facilities by mothers. And finally, the short-term child health, which is directly related to infant mortality. So we see improvement in coughs, diarrhea, and fever. The diarrhea numbers are negative, but statistically insignificant. So I'm not going to go through this. So the main takeaways of our paper is we find a significant impact of mobile technology, which was not designed to have effect on health. We will find negative and significant impact on infant mortality. And the effects seem to be driven by health knowledge, preventive behavior, and healthcare utilization. And this would have significant implication on how we value infrastructure projects in Africa. Thank you.
Perfect, thank you. That was exactly like 5 minutes. Great, perfect. Okay, so now we will proceed to the Q&A section of today's session. And actually, we had an interesting question coming while Eleonora was speaking from Richard Freund. Richard, I don't know if you can unmute yourself, and if you would like to do that, I think Natasha can help us unmuting you, and then you'll be able to ask your question directly to Eleonora.
Hi, can you hear me?
Yeah, we can hear you. Yeah.
Brilliant, thanks. Thanks very much, Eleonora. It was a really interesting paper. And obviously it was very interesting that you saw no differential effect between the school treatments or the bundled treatment with households as well. But I was just wondering, within your school treatment arm, there are quite a few different interventions or aspects that are bundled together, you know, both the infrastructure aspect and education, both the extracurriculum, but also the within the curriculum arm. Do you have any insights whether, you know, quant or qual, which is kind of driving your results at all? Or is it just, you know, you can only look at the bundled intervention as a whole?
Thanks, Richard. This is a really, really good question. And I think at the moment we haven't really thought a lot yet about the fact that this indeed is this multifaceted intervention where indeed we have on the one hand the sort of hardware that is being improved or installed, and on the other hand more the software when it comes to training. This is a bit sort of, you know, what I'm thinking right now, but the fact that we find nothing on these pre-nurse girls suggests to me that the hardware alone is probably not sufficient, because there doesn't seem to be any effect on girls that are not targeted by the training that really talks about menstrual health, etc. So of course these improved facilities would benefit everyone who comes to school, but apparently there's nothing there that really affected these particular groups of girls that were not yet menstruating. So that might be a first sort of hunch that it might be more related to the actual training and the curriculum than the hardware that was installed. But this is really just, you know, off the cuff. So it's definitely something that we still have to look into to sort of try and see, because our data are quite rich. Of course, given the time span of the presentation I had, I didn't present all of the results and all of the data that we had, but there might be something in the data that we could actually more substantiate our claim that, you know, it might be this versus this. But at the moment, we haven't really gotten there. So one of the things that we also did, which I also didn't discuss during the presentation, is that we did a cost effectiveness analysis, which is really interesting given that we have this bundled component, whereas there's absolutely no differential effect between treatment arm 1 and 2. And I think that is something that we also still need to dig a little deeper in, but that's definitely something that we will do. So I'm not sure if I answered your question satisfactorily, but I think that's where we are right now.
Thanks. Yeah, that makes perfect sense. Thank you very much.
Wonderful. Thank you. And thank you, Richard, for that question. If any of our, you know, our listeners have any other questions, please just keep them coming. I have a few questions written down for our speakers, but I also wanted to open the floor for our speakers to ask questions among yourselves. If you like had any questions during each other's presentations, please feel free.
Oh yeah, I just sent one in the group. Kibrom, I think that's, thank you for your presentation. I thought that was super interesting. Could you, I like am not an engineer, so could you give a little bit more background between the link between like lightning and cell phone coverage? Because like my intuition when you talk about it was that like how severe does lightning have to be to affect cell phone coverage? Because if it has to be truly severe, then like, is it possible that people are creating cities and areas without severe weather, and cities by nature have better cell phone coverage and higher healthcare quality, which would be a threat to validity, right? Oh, you're muted. There you go.
Yeah. Thanks, Daniel. This is an interesting question. And when I presented this paper a couple of times, that's the key questions. People seem surprised about lightning as an instrument for mobile coverage. It relates to the electrical component. So actually the greatest threat, the way I see it, is because it affects electrical equipment, it can affect electricity coverage as well. So if electricity coverage in an area is affected by lightning, and if there are blackouts, for example, then some health facilities will probably lose service for a few days, and that would affect health outcomes in the area. So there are several ways this IV may fail the exclusion restriction. So we conduct a bunch of robustness checks. But going back to your question, the engineering question, I'm not an engineer myself. So what I can tell you is it causes voltage surge during electrostatic shocks during the lightning, leads to voltage surge that affect, voltage surge. Maybe here we have voltage surge controlling equipment in the African context. I remember our TVs and radios, I'm from Ethiopia, would get damaged like periodically. It happens. You have to replace parts of it. And it's fairly common. So in the context of study the African, to give you an idea of how common lightning activity is, so the global average for lightning activity is roughly 2.3 strikes per kilometer square per year, roughly. In Africa, it's almost 18 per square kilometer per year. That is roughly 6 times more. There is more activity. So just simply, if you look at a cross-section of data, then lightning activity is higher in Africa, and probably it's going to be, I haven't really checked it, but probably higher in the tropics as well. So the way I see this affecting mobile coverage is because, so during the construction process, so these equipments get damaged. And my guess is these mobile operators have experience of that. So in areas where lightning activity is higher, they probably need to install the surge protectors. In other areas, they don't. So because of the cost of these surge controllers, they probably be slower in rolling out the technology in these areas. That's where this is coming from. But as you said, there is a threat to identification, the exclusion restriction, and we have a bunch of robustness checks. So we see, for example, no impact on reliability, electricity reliability in Africa, no impact on quality of health services in Africa, kind of number of days health facilities were not operational, kind of the number of hours they were not working, number of health workers who missed work, etc. So we have all these checks to establish, but I will say it's very right.
Cool, thank you. Yeah, and you preempted my question about blackouts too. This was super creative. Thanks.
Yeah, Sadia, you have your hand up.
Yeah. So again, question from Kibrom. Do you have any information on health behavior? Like, does this health knowledge actually translate to people changing their behavior? Do you have any information on that just to validate that channel?
Yeah, so our data is the DHS, so we haven't designed our own survey. So there are some questions in there that look like they capture preventive health behavior. For example, the use of insecticide-treated bed nets for both mothers and children. So disposal of children's stools, hygienic practices. We see improvement across the board for these outcomes. And of course, unless you design your own questions survey, you don't have like ideal variables, but we have kind of proximate variables in there that kind of suggest that's happening, kind of the preventive health behavior. So would something like that convince you, kind of the use of bed nets, hygienic behavior?
Okay. Yeah.
Okay, great. Eleonora, you have your hand up.
Yes, I have a question for Sadia. So maybe I missed it, but one of your outcomes shows that women that took up the treatment that were exposed to the treatment felt less sick or felt less sick, right? And I was wondering, given I would expect that women would only use this telehealth service once they fall sick, how would the exposure to such a service lead to less sickness overall? So could you explain a little bit more on how that could potentially work?
So again, we're just to reiterate that these were self-reported measures. So we're not actually observing that behavior. This is just what the females are feeling. So again, I think maybe we do find a correlation, and maybe we can check into it, that mental health and physical health are correlated, right? So just the fact that they know that they can consult or use a service which is so readily available to them at an affordable price, that does affect your mental health and consequently your physical health as well. So probably something along that channel could be at play here. But you're right that there's no like one way of ruling it out, but it's just like we're just hypothesizing or just coming up with a possible channel for it right now.
Oh, thanks.
Great. Any other questions? As I mentioned, I have a couple. Yeah, Kibrom.
Yeah, can I get a quick question? This is to Eleonora. I may have misread one of your slides. You show that the treatment leads to decrease in boys' grade, is it? Or is it a gap between boys and girls' grade? Just maybe the last slide.
Can you repeat it? So the only result I have on boys is that whether they are less likely to, whether absenteeism decreases for them.
Oh, okay.
Yeah.
So clearly I misread it, that's why.
Yeah, I rushed a little bit that last minute.
No worries. So for example, I have a question for Daniel. I was wondering if you could tell us a little bit more of the role of each of the components of the intervention and which of them matter the most, because if I'm not mistaken, it had 3 components, right? I don't know if you do some sort of decomposition analysis or something like that, and you could just have some insights into that. And if I can, add another question to that, and this is really related to Eleonora's talk. Do you have any information on social attitudes towards family planning and reproductive health in general? How are, I don't know, well, obviously there is certain stigma associated to it. I was just wondering if women in your study are if the results are being driven by them realizing that these things are available, or rather that their perception of social stigma around it is changing because of the availability of this means. So I don't know if you can answer either of them or both. Yeah.
So I'm gonna go with the second one first, and then I'll go back to the first one. So this study was initially supposed to be done in Bujumbura, but because of the civil war there, we had to move it to Malawi. In a lot of ways, Malawi is actually kind of a bad context for the study, because the contraceptive prevalence rate in Malawi is 58% the year we started the study, which is like very, very high for sub-Saharan Africa. Like to give you some context, in Bangladesh, in the MATLAB study, where they also did a family planning study, the contraceptive prevalence was somewhere around 1%, right? So we view the results here as a lower bound for like the effects of family planning services, because in a different paper, we show there's a roughly 5.6% increase in contraceptive use that's really driven by a shift away from injectable contraceptives towards more implants and more IUDs. So we think it's not really an acceptability effect. there is clearly high demand for contraceptives within the long way, at least. We think a lot of it is knowledge effects and the fact that these things and the voucher, right? And that's kind of what we see when we do the decomposition. So getting to the second question, because it's offered as one comprehensive package, this was done in conjunction with the Ministry of Reproductive Health, and they didn't want to decompose the program. They wanted one comprehensive package because it's for policy relevancy, right? So we conduct a decomposition using the LATES, using treatment assignment as an IV for the different components, with the caveat that this is not causal because we're using the same treatment as an IV for different components, right? But at least correlationally, we see that there are large gains associated with use of the transport. And this is likely because women who are using the transport don't have other means of transportation and things like that, but there's significantly less usage of the transport than the counseling, whereas the effects of the counseling are smaller, but since more women were exposed to the counseling, we actually see that the counseling is what's driving most of the results. Because that's every woman got the way it worked was at the end of the baseline study, they got their initial counseling. So in a way, every woman was treated with the counseling. And then when we look at additional counseling, there was, I'm going off the top of my head, it's in the paper, but roughly 1/10 of a standard deviation increase, or maybe it was 0.05 standard deviation increase associated with each additional counseling session. Whereas for women who use the transport, it was roughly 0.4 standard deviation. So a huge impact on child health for less advantaged women who didn't have access to transportation to clinics ex ante.
Perfect. No, that's super interesting. Thank you.
Thank you.
So I wanna try something. I wanna go around the table of speakers and ask you to give us a 30-second elevator pitch for those policy minded people in our audience. What's the takeaway message of your own paper? What would you like policymaker to know about this? What's the takeaway message? And after we go through this round, I would like to go through a second round where you tell our viewers about exciting new areas of research. Where do you think your field should go in the future? Most of our audience are PhD students who might be thinking about new projects and who might find your own areas of research interesting. So, it's just a way of kind of getting the conversation started. So let's talk about the elevator pitch for policymakers. And I don't know, is there anyone who would like to start? Any volunteers or? Sadia, do you want to start? We can go in order. And you're muted.
Okay. In light of the ongoing pandemic, I feel like there is already, I'm speaking from the context of a developing country like Pakistan, there is an increased burden on frontline workers, right? So the use or to study the causal impact of something as simple as telehealth or telemedicine would be extremely useful, because we are talking about a subsample of females who are disadvantaged. They come from low-income background. They do not have access. They're not very financially stable, and they are below the average national income levels. So to make health care accessible to such people, I feel is such an important issue. And our paper contributes to what kind of innovative products can be used to make health care or improve service delivery in the health sector.
Great, thank you. Daniel?
Yeah, sure. So there's a strong argument to be made that access to contraceptives and reproductive control is a human right, and that expanding access to programs like ours, as we've shown, it increases the use of contraceptives and improves birth spacing, stands on its own merit. So in a lot of ways, programs like this should be being expanded even before our paper. But our paper shows that there are positive externalities associated with this service, with this kind of service, that builds into larger development strategies and talking about like human capital growth in the long run, it shows that like as a development strategy, family planning impacts more than just the demographic dividend. It impacts child health and it impacts human capital growth, which should in the long run have impact on education, economic growth. So expanding access to contraceptives should be a priority for policymakers even outside of the reproductive health field. And in terms of like avenues where research is going, like most of my research doesn't necessarily focus on family planning. It focuses on just social protection programs for pregnant mothers. And a lot of it is dealing with like particularly pregnant postpartum women and showing that if you invest in these women, this has long-term impacts for children. So that's it.
Perfect, wonderful. Okay, Eleonora?
Sure. So I think the program and the study really shows that a multifaceted menstrual health program like ours can really have quite strong effects on important human capital development outcomes like school absenteeism, which is really, of course, a big issue when it comes to gender equality. So touching to aligning with the broader development agenda. I also think that the results that I didn't show on the cost effectiveness analysis, I think that's really telling, right? So often NGOs and organizations are really sort of fixated on, having more comprehensive and more intense interventions. But in this case, we had this bundled treatment arm where we actually had to go into the villages, had to do trainings with these parents, which is really intensive, very costly. And apparently it didn't really make any difference. So I think that's very important for policymakers to actually consider when they design the interventions that are focusing on topics like this. And a final thing is that, so what we did was looking at base and midline results. COVID hits right during the period between the midline and the end line. And I think when it comes to the sustainability of results, that's of course a really important question to ask here, because we also know from at least anecdotal evidence that during COVID in countries like Bangladesh, girls that were taken out of school because schools were closed did actually not return. So it would be really interesting to see, what an effect COVID may have on interventions that initially may have appeared very successful, but then because of COVID, we actually might not find such big effects anymore. And to combine this with your second question, where does the field go? So this is not necessarily my field, so health and economics, but I would think when it comes to, and I think this is more broadly applicable. So what we show is that survey questions alone are quite tricky, right? So when it comes to sensitive questions or questions for which there are clearly perverse incentives to misreport, it might be very useful to really think about, can we do something else in addition to survey questions? So observational data like we did, or maybe something else, incentivized experiments that of course also abound, might be a way to sort of complement survey questions.
Perfect, thank you. And we're already over time. Kibrom, if you wanna wrap things up in like 20 seconds.
Okay, I'll take the 20 seconds. Okay, so we know mobile digital technologies, broadly speaking, have effects on opening of firms, firm productivity, social empowerment, political empowerment. So in this paper, we add another layer to this, kind of the health impacts of these technologies. So in terms of policy implication, this is what I'll say. In evaluating the impacts of infrastructure, we incorporate all sorts of positive spillovers. So health impact has potential to make a lot of difference in how we value infrastructure. So because mobile technologies are not meant to kind of impact health outcomes. In terms of where the field is going, so primarily my area is kind of early shocks and health outcomes. That's where I work, the area I work in. So the field is going in the direction of multiple shocks. How, say, for example, in this case, a policy shock of access to mobile coverage interacts with other shocks, can be reducing the impact of other shocks on early and adolescent outcomes or labor market outcomes of what kinds. That dual shocks is where I think the literature is going.
Perfect. Thank you. Thank you. And that was a really concise wrapping up. Well, okay, so we're pretty much done. Thank you all very, very much.